Welcome to Road to Resus, day number 2. I'm Ashley Liebig.
And I'm Rueben Strayer. Don't forget to log into slido.com, event code SMAC. Select SMAC day number 2 so you're ready to vote. Yesterday, we managed a young woman who was badly injured in a motor vehicle collision. Her baby daughter died on scene. You voted not to tell her. She needed her airway managed rapidly. You voted to place a supraglottic. She showed signs of exsanguinating hemorrhage. You voted to give her blood pre-hospitally.
So now she's in the emergency department. She's obviously very ill, and the resuscitation has commenced in the trauma bay. Surgeons have asked you now to intubate this patient for a likely trip to the OR. So now it's time to intubate.
There are so many choices around how to intubate this patient who has marginal hemodynamics and is therefore physiologically difficult to intubate, and also is going to be held in C-spine precautions, so it's going to be anatomically difficult to intubate. One of the choices you have to make is, are you going to use a Boujee or use a conventional intubating stylet?
Ooh, and how about today? We don't vote until you hear from the experts. Let's do that.
Everyone had an opinion on Boujee versus stylet before Brian Driver did his randomized controlled trial on Boujee versus stylet that he published in JAMA last year.
Hey everyone, I'm Brian Driver from Minneapolis. Hope you're having a great time in Sydney. The Boujee's long been a standby for difficult or failed airways. The biggest reason? It's narrowing. What's easier, putting a small thing into a hole or a bigger thing? Carnival games thrive on this concept. Think ring toss, ball throw. This is why you get more points when the skee ball lands in smaller holes. The relative size of the ball to the target is crucial. Think Boujee versus tube entering the glottis. The Boujee was designed specifically for tracheal cannulation. The tube, on the other hand, was designed as a conduit of air to the trachea. Styletting the tube only partially addresses its shortcomings. And when you try to pass the tube into the airway, the cuff usually obscures your view. Also, the Boujee is self-confirming when you feel tracheal rings and the hold-up sign. Given all this, it seems obvious that the Boujee should be more successful. Indeed, in our recent trial, the success of the Boujee was substantially higher. So the only reason not to use the Boujee routinely would be if it had significant downsides. Some have speculated that 1, the Boujee is slow, and 2, the Boujee causes injury to the airway. First, regarding speed. In our trial, intubation time was similar or faster with a Boujee. I believe this is because the Boujee makes cannulation more facile and quick, mitigating the delay in advancing the tube. Second, regarding Boujee-related trauma. This does happen. There are 18 case reports in the past 40 years, but there's no evidence and no reason to think that injury to the airway occurs more often with the Boujee compared to the tube. A final possible objection is, why not save a Boujee for the tough airways and use a tube for easy airways? Because you should perform a critical procedure the same way every single time, rather than waiting until after obtaining the laryngeal view to decide which device to pass. Reducing cognitive load during critical procedures is clearly important, and you can't get good at something you do rarely. Boujee use requires practice. You should practice on your routine intubations so that when a difficult intubation comes along, you're ready. Waiting for difficult airways to use a Boujee is like a firefighter waiting for a fire before ever using a fire.
I'm going to call for a verbal vote.
All right.
All right, well, the Boujee since then has been in high regard, but not everyone is convinced.
Greetings, SMAC. Greetings, Rueben. My new friend, Brian Driver. I want to give a shout out to Roger, to Ollie, and to Chris. Thank you for bringing SMAC to the world. This is Rich Levitan from my house in Northern New Hampshire, and I want to share with you why, although I still love the beloved Boujee, for most intubations, I am a stylet guy. Now, the Boujee does have a smaller outer diameter, 5 millimeters, versus the tracheal tube, which is 10. And the Boujee is more forgiving. If you go down the blade, even right down the line of sight, you cannot block the target. But with the tracheal tube properly shaped, straight to cuff, 25 to 35 degrees, and on insertion, you stay below the line of sight, you come up from below, And as you pass into the trachea, rotate it rightward,
He may not have opened it.
and it
Yeah.
will dive into the trachea without mechanical impaction. The reason why I am a stylet guy for most cases is because it's simpler and faster than most airways. Congratulations again to Brian on that great article in JAMA. I wish all my friends in Australia a great last final smack.
Thank you, Rich. Yeah.
So now we'll decide.
Time to vote. What's it going to be? Boujee or stylet?
Is it there?
Slido working or Slido not working? Oh, we got Slido.
There we go.
We've got. So yesterday, by this time, we had about 1,700 votes, and now we have 24. So I'm going to attribute that to a slow Wi-Fi. All right. If
think it's
anyone
pretty
here
clear.
wants to make the case for a stylet, yell loud. Who here wants to make the case for a Boujee? Okay. Boujee it is.
Perfect. All right, so we've decided on the Boujee. So the next question is, we are going to RSI. Do we choose rocuronium or succinylcholine as our paralytic agent?
Hello to everyone at SMAC down in Sydney, way down under. I'm all the way up here in Los Angeles. You can see my Los Angeles Dodgers shirt. There you go. At Stewarts House, and I'm here to talk about rocuronium versus succinylcholine. I specifically asked to do so by Ruben Strayer. I understand you guys are doing a case. You don't know how it all turns out yet. And I think that's one of the things I want to start with right off the bat, which is that the emergency department's a different place than the unit. In the emergency department, surprises may yet announce themselves to you as you learn what's going on with the patient. Oftentimes in the unit, 95% or 99% of the diagnoses and database are available. But in the emergency room, diagnoses are still emerging. Things like seizures, subdural, subarachnoid, spinal cord injuries, things are becoming available to you as you continue the workup. Now, for the purpose of this discussion, let's avoid some of the stupid arguments. So we're going to assume that you're using optimal doses of rocuronium and optimal doses of succinylcholine, so we're not having that get in the way. Problems with both drugs occur when you don't use them in the appropriate doses. And for emergency department intubations, I assume you're using upper dose rocuronium to get there as fast as possible. Let's also assume that Sugamidex is not universally available. So while we may get to a point where we want to talk about reversing someone's Sugamidex, and it is available in some places, it's not available for me in most of the places that I work. So let's yield me on that. We can have that Sugamidex discussion in a different way. All right, so let's start talking about the properties of the drug and what some of the literature says about them. And succinylcholine, I think we all can agree, it's faster on and faster off. How much faster using the appropriate doses is a matter of debate, but I think the number's 30 seconds faster, 45 seconds faster in a 3-minute intubation sequence kind of thing. That fasterness, if you'll allow me fasterness, that fasterness can be really important to someone with severe respiratory distress, a crashing asthmatic, a hypoxic COPD, or a failure patient. But I'm not really here to talk about that per se, but that fastness is an advantage. What I want to talk about is the intubating conditions you get at the end of that fastness. And the intubating conditions with succinylcholine in almost every paper that's looked at it are better. Whether they rate them as excellent intubating conditions and then very good. In almost every paper that's looked at this, succinylcholine gives you a little more excellence and more very goods depending on how you go down the scale. So the very best intubating conditions are achieved more frequently with sucks. More importantly, and almost never talked about because very few studies quote it, every once in a while you give it a paralytic agent and you get unacceptable intubating conditions. That is obviously a very bad place to be and a place I'd like to avoid at all costs. And in the papers that have that data available, it appears that rocuronium gets you there, not commonly, but a little more commonly than succinylcholine. So unacceptable intubating conditions after it sucks, in the few papers reporting it, 1.5%, 2%, 2.5%. In the papers with rock reporting this, it's 6%, 7%. 2 to 3 times more. That's really bad. That's a real problem place I don't want to be in any emergency department intubation because, unlike in the unit or for the anesthesiologist, cancel the case is not part of my algorithm. Okay, so faster on is really important. Really good intubating conditions is really important, especially if you work as I do often with Resus. I don't want a less experienced intubator to fail on their first pass because the drug they chose didn't give them the best chance possible of success, the most excellent of intubating conditions available. And I think sucks does it more often. Next, I want to talk about fast off. We all know sucks wears off in about 15 minutes, and the rocuronium, particularly at the upper doses, you might be stuck for an hour, you might be stuck for 90 minutes without any neurologic exam available to you. And because many of the times I'm working in an emergency room, after they're intubated, what follows is the imaging. And when that imaging comes back with a subdural with a little bit of shift or a subarachnoid, or there's some suspicion that the patient might have had a seizure over there in the scanner or along their workup, or maybe even from the pre-hospital care setting, if I don't know if they're seizing, then I'm not managing their seizures. And so fast off is an advantage for all that. I just was in Hawaii with the UCSF group, and I heard a neurologist talking about stroke exam and possible seizure problems and how important it was to use succinylcholine in these types of cases because she does not want to be denied the exam, and specifically she wants to know if they're seizing. Even with non-convulsive status, there's often roving eye movements and other hints that tell you that they're having seizures, all of which will be denied to you by choosing rocuronium, and they'll be denied to you for an hour or so. And so for me, I know I'm old, I got a gray beard, I seem stuck in a rut. Most of the SMAC people are probably looking like, who's this dinosaur? Why did you bother asking him? But I am still stuck on sucks, and I'll offer this one last point, which is that we have really large databases that tell us that sucks is a really good drug for this and that there aren't that many problems with complications or bad things happening in the National Emergency Airway Registry. NEAR 1, 2, and 3 are largely about succinylcholine rapid sequence, and that database suggests that sucks is an excellent drug with a really high success rate. We have no such comparator for rock as yet. So for me, I'm really happy that we have rock when there's obvious contraindications to succinylcholine, but I'm still mostly reaching for the succinylcholine for my first choice.
Thank you, Billy. It wasn't easy to find someone who was willing to speak in favor of rocuronium.
I should be on stage right now. Hi, Rueben. My opponent in this debate is Billy Mallon, who graciously agreed to do a 2-minute pro-succinylcholine video and then submitted to me a 6-minute pro-succinylcholine video. We're going to have to speed up this video for the sake of time, so just to keep things fair, I'm going to record this and we're going to play this video at the same speed. I don't want to be accused of taking any advantage. Okay, I'm just going to get comfortable here. All right. When I started talking about rocuronium a decade ago, just about everyone was using sucks, and now rocuronium is much more popular for very good reasons. And in many centers, especially academic centers, rock has taken the place of sucks as the dominant paralytic. So now I'm seeing a resurgence of interest in succinylcholine from folks who have little experience with it. Sucks is coming back into fashion. This is like bringing back into fashion asbestos. So let's go back over. There's much made about the advantage of sucks over rock in terms of view and the speed with which you get the optimal view of the glottis. But this is only a concern when you use the wrong dose of rock. Authors that conclude an advantage for sucks cite studies that dose rock at 0.6 milligrams per kilogram, which was thought to be the right dose for many years, but now we know the right dose is double that, 1.2 milligrams per kilogram. And at 1.2, the views are clinically equal. Cochrane states, quote, "We found no statistical difference in intubation conditions when succinylcholine was compared to 1.2 milligrams per kilogram rocuronium. The most recent NEAR registry study of 4,000 emergency patients found no difference in first-pass success rates, and in fact, rocuronium was slightly better in first-pass success. So I think that question has been settled. They're equivalent for view, but rock beats sucks on safety. There are a variety of contraindications to succinylcholine. All of them are uncommon and can be screened for if you're preparing to intubate for a tummy tuck. But we're not intubating for a tummy tuck, and I suspect most of you, like me, are not routinely screening for muscular dystrophies and a family history of malignant hyperthermia before tubing your obtunded sepsis patient. We don't know what our patient's serum potassium is. Remember, sucks causes a bump in everyone's potassium, which doesn't matter if your patient is eukalemic. But some of the patients we're intubating emergently aren't, and I suspect some of our peri-intubation arrests are from unrecognized hyper-K from sucks, and we never know. Rocuronium has no contraindications. Succinylcholine occasionally causes masseter spasm. It's rare, but I've seen it, and it's something you only need to see once to not want to see again. Sucks causes fasciculations, which use up oxygen and decrease apnea time in marginal patients. But the most important reason to choose rocuronium over succinylcholine is the very reason rocuronium is so often maligned: its long duration of action. Succinylcholine is classically recommended for its rapid offset in the event it cannot intubate, cannot ventilate. However, clinicians who rely on the return of spontaneous respirations in this scenario will usually be wrong, and being wrong here has the potentially disastrous consequence. Sucks paralyzed emergency patients will usually not start to breathe before critical hypoxia. When you push a paralytic on a sick patient, you are committed to establishing oxygenation for that patient, and if you go into RSI not mostly in, but all in, you will make better, safer choices during early management. Lastly, laryngoscopy doesn't always go as smoothly as planned, and I have seen 2 patients who intubated with sucks die because they regained muscle tone in the middle of a difficult laryngoscopy, vomited, and had a massive aspiration event that killed them. I've seen this twice, and both of those patients would have had a different outcome had the providers chosen rocuronium, because when you push rock, no matter what else, your patient is going to remain paralyzed, so you have complete control and safety for as long as it takes to manage the airway. Rocuronium's long duration of action turns out to be its most important advantage. All right, back to you, Ruben.
All right, thanks, Ruben. All right, so what's it going to be, guys? Time to vote. Are we going to rock the rock or suck the sucks? Okay, sucks is gaining, but I don't think it's going to get there.
All right. So despite these airway controversies, we have successfully gotten this patient intubated, and we're doing absolutely everything we can to save her life. We have bilateral chest tubes in place with an initial output of 200 cc's. We have massive transfusion protocol in place via large bore vascular access, a pelvic binder. Bedside sonography shows a small pericardial effusion and hemoperitoneum.
But now what? This patient could have a severe brain injury or a thoracic injury or both. She definitely has blood in her belly and probably in her pelvis as well. She's not responding to our resuscitative maneuvers and the blood we've given her. Her blood pressure is low, it's in the 70s, her skin is clammy, she's still in shock. The surgeons at her bedside are arguing amongst themselves. They want to take her upstairs to the operating room, but they don't know what to do when they get up there. They don't know where to cut. A CT will tell us where to cut, but is she stable enough for CT? The surgery junior resident, registrar, suggests that we continue to resuscitate the patient in the trauma bay. He learned that from ATLS. You guys are going to have to decide what to do. Where are we going to go with this patient? What are we going to do for this patient? Does anyone have any suggestions?
Well,
oh, great. Great.
Ashley and the Ruebens? Look, I mean, when a patient is actively bleeding to death, nobody ever said, oh, thank God we've got the CAT scanner plugged in. And to be fair, I think the question of stable enough is probably the wrong question to ask. So we have to make a distinction here, I think, between a patient who's in shock and a patient who has active cavitary hemorrhage, right? They're different. A patient who's bleeding might not be in shock yet, and a patient who's in shock might not be actively hemorrhaging, tamponade being one example of that. Now, if you want to take a trauma patient in shock and you want to resuscitate them and make them stable enough for a scanner, which is kind of a problematic proposition anyway, fine, do that. You can probably do that pretty effectively. You can probably make any patient look good enough for the CT scanner, but that doesn't make it the right decision. Now, a patient that is actively hemorrhaging is different, and when you encounter these patients, you'll see it in your resuscitation. You'll go through your big trauma room interventions, and these are the patients who are going to respond transiently or not at all to your trauma bay resuscitation maneuvers. And when you see that, you need to think active hemorrhage, and a patient who's actively bleeding needs a surgeon, not a scanner. Now, I'm not a trauma surgeon, I'm a trauma team leader, so I work very closely with trauma surgeons in my job. And one of the things that's always been impressed upon me is how minimalist trauma surgeons can become in situations like this with active bleeding. Karim Broey, who's a trauma surgeon in London, does a wonderful presentation on minimalism in trauma resuscitation, saying that there are need-to-know things in trauma, and then there are nice-to-know things in trauma. And really, in his circumstance, he just needs a physical exam and a central pulse to decide what to do next. So a lot of other things might actually be nice to know. X-rays, maybe nice to know. Ultrasound, maybe. CAT scanner, definitely in the nice to know category. And once you start recognizing that, really what you're just doing is wasting time trying in vain to keep up with the resuscitation. Really, no matter how good your resuscitation is, you will only keep up but not maintain or replace that evolving coagulopathy and hemorrhagic shock. Now, trauma, more so than most diseases, is a disease of destination, right? It's about where you are, but it's also very much about where you're going. And it's probably useful to think of this not as an entirely binary decision, right? If you think of CAT scan or OOR, it's going to make the decision a lot harder. The reality is, a patient like this can go to the operating room, have their quadrants packed, and then go to CAT scanner to have their injuries further delineated. It doesn't have to be a one or the other proposition. So finally, the OR provides a default pathway for all patients with active exsanguination, such as the one you guys have told us about. And it's exactly because of its availability and simplicity that makes it the preferred choice for our patient.
All right, thanks, Chris. I wonder if there's anyone out there with an opposing opinion.
Thank you, Chris. I know you really did help me with my argument here, because really there is no clear answer. I think the number one thing that we can do is make sure that our trauma patients are being actively resuscitated while they're bleeding. And we can have a team-based approach to this. Sam, can you just help me with that blood so that we can resuscitate this patient while we take them to the CT scanner? The reason we want to take them to the CT scanner is because we can multitask while we're doing that. We can hang blood, we can continue to resuscitate the patient so that we can actually find out what's killing the patient. As Chris said, the patient may be exsanguinating, but they might not be. In fact, they might have another cause. And in this particular patient, they actually may have injuries from their cardiac or in their belly or even in their head, and we need to know that answer. Hey, Chris, can you stand up and hold this for me? We can actually keep resuscitating them and walk and talk at the same time. We can take the patient to the CT scanner and continue to pump blood, actively manage them, and then, even better, provide a shared mental model. You know that, Chris? The shared mental model of actually describing what is killing the patient so that the surgeon can actually open the right compartment first and then actually treat what is killing the patient straight up. Because not every trauma patient who's bleeding needs to go to the operating theatre straight away. In fact, many of them will have interventional radiology first up, or even more importantly, might actually go to the intensive care unit where our intensive care colleagues can manage them without ever putting a knife to the skin.
Thank you,
Thanks,
Claire.
Ashley.
Thanks
All right,
to both
guys.
of you. All right, so now, time is of the essence, guys. What should we do with this patient? This time you're going to free text, OR, CT, stay and play in the bay, or somewhere else. You decide.
Free text vote.
No one follows rules. Very nice.
All right.
All right, so we will wrap up our day today on day 2 for Road to Resus. We've learned.
We've learned that the Boujee can offer a significant advantage over the conventional stylet in a lot of airways.
We've also learned that,
We learned that rocuronium rocks and sucks.
I think that it's fair to say there might be 2 paralytic options available
And
to
that
us.
you should choose your paralytic based on the patient in front of you,
Yes.
and that you should definitely choose your paralytic based on the patient in front of you. You should choose rocuronium based on the patient in front of you.
And we have also learned that we are going to,
The trauma is a disease of destination.
I guess,
Trauma is a disease of destination. So
hybrid, I think they said.
a hybrid destination. So be deliberate about your destination. Once you've done your initial resuscitation and procedures, everything else can continue. You can carry on with the resuscitation in the CT. I was taught, many of you were taught, that you shouldn't take an unstable patient to CT. That's not entirely bullshit, but it's mostly bullshit. The vast majority of unstable trauma patients should go directly to the operating room. Some need IR, some need REBOA or ED thoracotomy. But one thing you do not want to do with your patient, your unstable trauma patient, is to continue to pour blood into an exsanguinating, unstable trauma patient as you watch them in the trauma bay. Either move them to their therapeutic destination or figure out exactly what's killing them in CT. Do not stay and play in the bay.
All right. Valuable lessons. We'll be back tomorrow for Road to Resus Day 3 in the ICU. Thank you.